Professor Ives Hubloue from Belgium. He is the chairman of the Department of Emergency Medicine at the University of Brussels and of the research group on emergency and disaster medicine. And he's also at the Faculty of Medicine and Pharmacy of the Vrije University in Brussels. Thank you.
Assalamu alaikum. First, I want to thank the organizing committee and the president for having me invited here. And I want to congratulate the Association on Emergency Medicine here in Bahrain for their first conference. This is a great achievement, and I'm very proud and I'm very honored to be here and to share this moment with you and meet a lot of friends. Mashallah. So I'm asked to give you a talk on the management of high blood pressure in the emergency department. And the subtitle is, Does the Number Matters? And we will see, in this case, you should treat the patient and not the number. And we have heard that before in other situations. It counts for this situation more as ever. I have no disclosures. And let's start with 3 cases. We just want to go through and we will take them at the end back and see how we should treat them. First case, male patient, 56 years old, severe thoracic pain since 2 hours. He presented with nausea and vomiting. At clinical examination, you see a blood pressure of 200 over 130 millimeters of mercury, a heart rate at 85, saturation 98. ECG is normal, chest X-ray, a bit of a wider upper mediastinum, and as we are all very skilled in ultrasound, we do a transthoracic echography, and we see a widening of the ascending aorta. CT scan revealed a dissection of the aorta. Okay, keep this in mind. The second case is a male patient of 35 years old. He is treated with a hypertension since many years, since 4 years, with a beta blocker, but the patient is known for a poor compliance. He takes his pills one day not, 2 days yes, 2 days not. And he presents, after he had a very emotional discussion with his boss, he presents at the emergency department with some thoracic pain, and he did not take his medication since 2 days. You see the clinical examination, you see his blood pressure. Quick setup was normal, and even the ecography was normal. The last case is a male patient of 65 years old. He has an hypertension treated with a sartan since 10 years. He just underwent some abdominal surgery, a cholecystectomy, went home after 2 days, and he represents himself again to the ED with some heavy lower abdominal pain since 2 hours. At clinical examination, you see what his blood pressure is, and by examining the belly, you feel like a mass in the lower abdomen. Okay? CT, chest X-ray, ECG, etc., all are normal. Okay? Keep these cases in mind. We will come back at the end. So, what now about that title? I would like to change the title, and I changed it. For me, it's to treat or not to treat. That's the question. And I'm referring to a very famous person who introduced that talk many, many years ago. It's William Shakespeare. So the learning objectives will be that. It's a bit of the summary of this talk. You will know, we will talk about the characteristics of hypertensive emergencies, urgencies. We will talk about treatment strategies, and we will also talk about what is called a pseudo-emergency, okay? So what is a hypertensive crisis? If we see patients in our emergency department, most of them with a high blood pressure, they don't have a hypertensive crisis. A lot of people, when you take their blood pressure, they will have an elevated blood pressure without consequences. So often we talk about this is what we call a pseudo-emergency. And a real hypertensive crisis is this one. A hypertensive crisis is a diastolic blood pressure above 120 millimeters of mercury. That's an emergency, okay? And we will see when it's an emergency. So when you talk about hypertensive crisis, you have two entities. The first one is the The first one is the hypertensive emergency, as we call it. It's the life-threatening situation with the diastolic blood pressure above 120. There is acute or progressive end organ damage. And this is a patient you should treat immediately and very aggressively. So this means intravenously, yeah? And it's not only blood pressure lowering, it's also, and we will see this, to prevent end organ damage progression, okay? The second entity is the hypertensive urgency. It's the same situation, but you don't have end organ damage in these patients. So there, it should be treated, but you have time. You don't have 3 days or 4 days, but you have time. You have some hours to treat it, okay? These are the two main important hypertensive crisis situations. So let's go more into detail on both of them. So the hypertensive emergency, the first one, the goal of the treatment is very simple. Two things. We will reduce, or we want to stop the end organ damage, and we need to reduce the blood pressure. How we will do that, you will see in a few seconds. The treatment principles are there are a lot of guidelines, but are very simple for me. You should reduce diastolic blood pressure to 110 millimeters of mercury, and this should be done in 60 to 90 minutes. 90 minutes is the duration of a football game, so it's long. So you don't have to do it in minutes. You have some time there, but no, don't take 1 day for that, okay? Or another guideline is saying you can reduce the mean arterial pressure, which is not the diastolic. The mean arterial, you know, it's 1 systolic plus 2 diastolic divided by 3. And you should reduce this to 120 millimeters of mercury, again in 60 to 90 minutes. This is an emergency. So you should treat this actively. The principles also, if you do that, you should use, and we will see that, the blood pressure lowering should be predictable and controllable. That's very important. You should use medications that you know, and that you know how they work, within seconds, within minutes, and so it's not injecting something to a patient and look how it's happened. You should have a control on that. Because a too fast reduction in blood pressure in certain patients, it's even harmful. You can even increase the end organ damage to that patient. And also, beware of the side effects of many antihypertensive drugs. They lower the blood pressure, but they do a lot of other things also. Okay? So it's very dangerous if you don't know them very well. So I already mentioned it, the characteristics of those drugs you use in this case, and whether you use urapidil or an intravenous beta blocker or an anapril or other intravenous antihypertensives, just know them. Know them, and also just be aware that your nursing staff who is applicating them knows them every detail on it also, okay? It should be predictable, and I always said it should be controllable. So you need to have an invasive blood pressure control in those patients. This means that that patient will not go to a standard ward for further treatment. He will go to the ICU, okay? This is very important to know in the hypertensive emergencies. What are hypertensive emergencies? This is a list of the most common life-threatening hypertensive emergencies. If you see that list, we can go through, but you can read all. It's something you don't see every day, fortunately. But be aware, if you have a patient with one of those things, like the first case, I discussed the aortic dissection, this is an emergency, this should be treated with priority, okay? Now let's go to the second step. It's the hypertensive urgency. There, the goal of the treatment is also to reduce the blood pressure, but we have time, slowly. We have 1 day time to do that. It's not necessary to drop that blood pressure immediately. But it's very important that you follow up that patient, because if you send him out of your ED, he should be followed up by the GP or in the outpatient clinic, because maybe he can present with an hypertensive emergency the day after. So this is a patient you should keep under control. Okay, don't let him go into nature like that. Treatment principles here, very similar, but you have time. The first thing you can do is bring the patient into a quiet environment. Now, is an emergency department a quiet environment? No. So keep him out of the emergency department, maybe in your waiting room or something where he can be at his rest. And in 30%, there are studies, in 30% there is a normalization of the blood pressure without doing anything. Okay? If the blood pressure is still high and the patient was under an oral treatment and with a poor compliance, you can restart this habitual treatment. That can help, okay? And if it is a new patient, you can start with an oral treatment, okay? If you start a new medication, as I said, you need to follow up the patient because he started with a new medication. So he should be controlled by the GP the day after or at the OPD in the hospital after 24 hours. Now, what are the medications you will use? Mostly oral. Again, you should know how they work, and your nursing staff also. Take into account associated diseases with the patients. Don't give beta blockers to asthmatic patients, they don't like it. So yeah, then you can choose another one. And mostly we use beta blockers or calcium channel blockers. These are the most common used oral medications in these kind of urgencies. What now about a pseudo-emergency? That's a case where the blood pressure is elevated, and often it's an isolated systolic high blood pressure, 240, 250 millimeters of mercury. Very impressive, a very impressive number, but without clinical signs. And there it counts that you should treat the patient and not the number, okay? In patients with a chronic hypertension, it is no need to lower that blood pressure acutely because you will do harm to that patient. If this is a geriatric patient with carotid stenosis and you lower a blood pressure too hard, you will give them a problem, okay? So often those kind of things occur in a post-operative phase, like people with pain, anxiety, hypoxia, or urinary retention, and they have pain, so their blood pressure raises. It's like us. So don't treat the blood pressure, but treat the cause that is underlying. And so that's the pseudo-emergency we're often confronted with, and we don't have to treat it with medication at all. So let's come back to the first case. You agree this was an emergency, this is a dissection of the aorta, should be treated promptly, okay? The blood pressure was high, so this patient was treated with intravenous antihypertensive drugs. The second case clearly was an urgency. The patient had some emotions with his discussion with his boss. We took him in a quiet place, lowered the blood pressure, and maybe we restarted his medication he was used to take, okay? And the third one, this was absurd. Probably he had the lower abdominal pain and the distension was the urinary retention, because he got a lot of morphines. He was a 65-year-old patient. He got a lot of morphines after his operation, and he got a urinary retention. So solve that problem, and you don't have to treat the blood pressure at all. So in summary, I think I'm on time. In summary, you know what characteristics of hypertensive emergencies are. They are very rare, but be aware, if they are there, you need to act. The hypertensive emergencies, okay, it's an urgency, but you have time to treat. The pseudo-emergency, think twice. Don't treat the blood pressure, treat the patients. In the other case, also treat the patients, of course. And you should know how to do it. If you use medication, please, for me, whatever you use, just know how it works and be aware that your nursing staff also knows all the characteristics of those medications. This was my message. The references are there. And this is a last slide of, you know that? It's Brussels. It's a nice city. This is the Atomium. If you visit Brussels, it's worldwide to visit it. It's a nice restaurant on the top. And we have a view on the skyline of Brussels, which is far less impressive as skylines here, but it's a nice restaurant. And thank you very much for your attention.